This lecture provides a brief overview of asthma care. The objectives of this lecture are to recognize signs and symptoms of asthma and be able to recommend appropriate treatment based on patient conditions. After this lecture, one should be able to make recommendations for monitoring and be able to provide counseling to patients regarding the disease state and relevant treatments. There are two major guidelines for asthma: the GINA guidelines, last released in 2017, and the National Asthma Education and Prevention Program EPR 3 guidelines, last updated in 2007. Due to recency of this publication, this lecture will more closely mirror the GINA guidelines. Asthma epidemiology may vary from country to country, but the management does not differ except in regards to monoclonal antibodies used as last-line therapy for refractory asthma. This is an outline of what will be covered in this lecture. Asthma affects an estimated 300 million individuals worldwide. There are 70 to 90 deaths per year in Hong Kong due to asthma, which shows a low mortality rate like other countries. However, 80 to 90% of these deaths could be avoided, as most of these deaths are due to delayed treatment and lack of understanding. This graphic shows the incidence rates of asthma around the world. It is largely a socioeconomic and environmental related disease state. You can essentially predict which countries have a higher incidence of asthma by looking at a map of countries by GDP or gross domestic product. The wealthier the country, the higher the incidence of asthma. Due to this, asthma rates in Hong Kong more closely resemble wealthy Western countries such as the US, Canada, Australia, and the UK, than more closely genetically related countries like mainland China. On this map, Hong Kong would be bright red. Asthma is a chronic inflammatory disease of the airways characterized by reversible airflow obstruction. The key word here is reversible. The respiratory symptoms will vary over time and intensity. Lung function tests are measured to determine this variable airflow limitation. Symptoms of this respiratory airflow obstruction occur or are worse at night or upon waking. The symptoms are often triggered by exercise, laughter, allergens, cold air, among other triggers as well, and occur or worsen with viral infections. The four primary asthma symptoms are coughing, wheezing, chest tightness, and shortness of breath. The cause of asthma is multifactorial, with genetic components including a correlation with allergic rhinitis, eczema, or a family history of asthma. Environment also plays a significant role that influences asthma. There are numerous risk factors for an asthma exacerbation. A key to asthma prevention is to avoid triggers that can be avoided. However, not all triggers are avoidable. A key trigger to help patients avoid are medicines that can trigger asthma, such as paracetamol, aspirin, NSAIDs, sulfites, or non-selective beta blockers. Exercise is difficult to avoid, as not exercising can lead to other metabolic problems. But exercising in a cold, dry climate, that can be avoided. Many emotions can lead to an asthma attack, including anxiety, laughter, and stress. Lung function should be monitored before starting treatment. 3 to 6 months later, then periodically. Periodically is defined as every 1 to 2 years in adults and more frequently in high-risk patients and more frequently in children based on severity and clinical course. Also, after an exacerbation, a comprehensive review should be performed within a week, including an evaluation of signs and symptoms, pulmonary function, quality of life, exacerbations, adherence, side effects, and patient satisfaction with treatment. Symptoms over the last 4 weeks should always be assessed. Other treatment issues should be examined, including adverse effects, inhaler technique, and adherence. Comorbidities such as GERD, rhinitis, obesity, obstructive sleep apnea, depression, and anxiety play a role and can also influence asthma control and management. There are 2 main forms of monitoring lung function: peak expiratory flow rate, which is generally done at home, and spirometry, which is generally done in the office. Peak expiratory flow rate, or PEFR, can easily be done on a handheld device as shown on this slide. And then the values obtained are compared to charts with normal values of same gender and similar age, or, if known, the readings can be compared to patients' baseline reading from when they were completely asymptomatic. However, there are limitations of PEFR monitoring, including that the charts of healthy individuals' average have variability of up to 20%. When a patient feels as though they are having an asthma exacerbation, they blow on peak flow meter and compare the value to their baseline reading using the traffic light collar chart shown here. Green, which is 80% or more compared to their baseline value, means that no action is needed. If the measurement is 50 to 80% of their baseline value, then they likely need to take some puffs from their bronchodilator inhaler. If less than 50%, then more aggressive management is warranted. Spirometry also measures FEV1 and FVC. FVC is forced vital capacity. FEV1 is how much air the patient can blow out in 1 second. An improvement of 12% or greater and 200 milliliters after usage of a bronchodilator shows a response. FVC is the total quantity of air that can be blown out by the patient after a deep breath. This is often put into a ratio with the FEV1 to differentiate between obstructive problems such as asthma or a restrictive problem. There is a lot of information on this slide, but the only point I want to emphasize is that when diagnosing, you need a history of variable symptoms and evidence of variable airflow limitation. The methods of showing variable airflow limitation are listed here. When assessing a patient's level of symptom control, these are the 4 questions you ask. A patient is given a point for every yes answer. Then, based on the score, you categorize whether the patient is well controlled, partly controlled, or uncontrolled. You can then maintain current therapy or advance to more intensive therapy. The goals are pretty simple and straightforward for patients. We want to reduce intensity and frequency of exacerbations while minimizing adverse outcomes. Reducing impairment is referring to freedom from frequent or troublesome symptoms of asthma, including cough, chest tightness, wheezing, or shortness of breath. Also, using salbutamol for less than 3 days per week, having night awakenings of less than 3 times per month, maintaining normal activities of daily living, and satisfaction with asthma care on part of the patients and their families. The first treatment approach is to address modifiable risk factors for exacerbation and find ways to minimize or eliminate these risk factors, or at least approach these risk factors in a cautious and well-informed manner. Fun fact, in case I'm losing your attention at this point, probably the most famous person with asthma right now is David Beckham. So now that I have regained the girls' attention in the class, let's talk about many non-pharmacologic treatments that should be utilized in asthma. Firstly, you should always address the modifiable risk factors mentioned previously. Next, address smoking and occupational asthma. Counseling on adherence, technique, and maintaining a current food and drug allergy list are other things that should be done. Before choosing asthma therapies, one must first classify the stage of asthma. Asthma is classified as any of four categories: intermittent, mild persistent, moderate persistent, and severe persistent. Based on this classification, you will then know which step of treatment to move the patient to. The steps the patient should start at are shown on the bottom of the table. Classification of asthma is based on many factors, including symptom frequency, nighttime awakenings, SABA usage, and others. This is probably one of the most important slides from this lecture. Based on your classification from the previous slide, you will then recommend treatment based on the stepwise asthma treatment approach. Patients with intermittent asthma should be started on step 1 and are being provided a salbutamol inhaler, whereas a patient with daily symptoms and nighttime awakenings twice a week would be classified as moderate persistent and then be started on an inhaled corticosteroid and a long-acting beta agonist. If treatment does not adequately control symptoms, then therapy should be stepped up, or if the patient has good control for at least 3 months, you can also consider stepping down, as the goal is to use as little drug as possible while maintaining control of asthma symptoms. The preferred option is listed in the top row. However, there are some alternative options that can be used as shown in the middle row. Leukotriene receptor antagonist montelukast is generally preferred over theophylline due to a better side effect and toxicity profile. And on the bottom shows that all asthma patients should be prescribed a short-acting beta agonist regardless of their classification. This is a version I created that is a bit more specific and lists the preferred agents at HA hospitals here in Hong Kong. Stepping down therapy should be avoided in situations such as pregnancy, travel, or unstable comorbidities. These may influence asthma symptom management and increase chances of a failed therapy de-escalation. A more frequent follow-up visit should be planned after any change in therapy, whether escalating or de-escalating. Also, stepping down therapy should be done in the smallest increments possible. It is key to ensure a patient with asthma knows how to appropriately self-treat themselves, particularly in Hong Kong, where many of the medications used to treat asthma are available over the counter without a prescription, unlike many other developed countries. Upon experiencing symptoms, the patient should administer their salbutamol inhaler. They may take 2 treatments of 2 to 6 puffs 20 minutes apart. Then it is important for them to assess the level of response they have had to these initial treatments. If the patient's peak expiratory flow rate is at least 80% or they no longer have wheezing or dyspnea, then it is considered a good response and no urgent treatment is needed. The patient should try to learn from the experience by documenting any potential triggers or situations that led them to requiring their inhaler. If the patient's PEF rate is only 50 to 79%, then they need to contact a clinician and continue using the salbutamol inhaler. If the PEF rate is still less than 50%, then they need to visit the A&E department, consider calling the emergency services number 999 for ambulance transport, or if someone nearby can provide rapid transport to the hospital. Upon arrival in the A&E, management will then be based on severity. The first goal is to provide oxygen to achieve an O2 saturation of greater than 90%. Also, a short-acting beta-2 agonist and ipratropium will be provided, usually via nebulization, every 20 minutes. A course of oral or IV corticosteroids may be initiated, and occasionally some adjunctive therapies will be done, including magnesium as a smooth muscle relaxant or intubation and mechanical ventilation for optimal control of the airway. Now, let's discuss the drugs used more specifically. The first, most commonly used asthma medication is salbutamol. It has many brand names, but the most common is Ventolin. It is available as a generic nowadays, which has made it cheaper than previously, which is great as it is a life-saving medication. In addition to asthma, it can be used prophylactically for exercise-induced asthma. For exercise-induced asthma, it should be administered 15 minutes prior to activities. The graphic here shows how rapidly the peak expiratory flow rate can decrease during exercise in asthmatics, the red line, versus healthy individuals, the black line. Similar to Australia, but different from the US, salbutamol can be purchased from a pharmacist without a prescription from a physician. Salbutamol is very well tolerated. Side effects are usually very mild and transient. It is extremely rare for a patient not to be able to tolerate the side effects or the patient to be allergic to salbutamol. For asthma, inhalation is preferred over the oral or parenteral route. Salbutamol has minimal drug interactions. The one worth noting is non-selective beta blockers, which should generally be avoided in asthma patients anyways. Salbutamol does cross the placenta, but it is still the preferred SABA in pregnancy. Having a hypoxic mother is worse for the fetus than taking salbutamol. Monitoring is occasionally done for salbutamol, including heart rate, as there may be mild increases in heart rate. Plasma glucose and pulmonary function tests may also be done throughout the course of therapy. Potassium is pushed back inside the cells by salbutamol, so sometimes potassium level monitoring may be utilized. Salbutamol is the preferred agent for emergencies as it starts to work in about 3 to 5 minutes, and peak effect is seen between 10 and 30 minutes after administration. Systemic corticosteroids are often used in asthma exacerbations. They are generally initiated within an hour of presentation to the A&E. A short course of oral steroids have been shown to reduce the rate of relapse and the rate of hospital readmission. GINA and EPR3 guidelines prefer oral administration over parenteral administration of corticosteroids because it is less invasive. except in patients with absorption problems or those who are not able to tolerate taking the medication orally due to the severity of their respiratory distress or because they are vomiting, in which case parenteral therapy will be utilized. No additional benefit is seen with courses longer than 5 days or using a taper instead of a fixed dose schedule. As you are well aware by this point, systemic corticosteroids come with numerous adverse effects. Cushingoid is a mnemonic to help you remember the adverse effects associated with steroids. Next, let's discuss the short-acting inhaled anticholinergic ipratropium, or brand name Atrovent. Ipratropium is generically available. It is added to salbutamol in acute asthma as it improves lung function and reduces chance of hospital admission compared to when salbutamol is given alone as monotherapy. Ipratropium is very poorly absorbed and therefore virtually has no systemic adverse effects. Local side effects include very benign adverse effects such as dry mouth and bad taste. It is safe to administer in pregnancy and has a rapid onset of less than 15 minutes with a duration of action ranging anywhere between 2 and 8 hours. Ipratropium, much like salbutamol, is available via a pharmacist without a prescription from a physician. However, when you combine ipratropium and salbutamol into one convenient inhaler, Combivent, it does require a prescription for a reason unknown to me. In a refractory acute asthma attack, sometimes intravenous magnesium may be administered as a 1.2 to 2 gram infusion one time. Some studies have shown that magnesium can reduce hospital admissions. Adverse effects with magnesium are uncommon. If the patient's asthma is severe enough to require intubation and mechanical ventilation, ketamine may be the preferred sedative for the intubation procedure, as it causes bronchodilation. Let's switch to agents used in the routine maintenance management of asthma. Inhaled corticosteroids are effective and commonly used agents for asthma. Budesonide, or Pulmicort, is the hospital authority preferred agent. However, there are many other inhaled corticosteroids commercially available in Hong Kong. Cyclosinide, or brand name Alvesco, is different than other inhaled corticosteroids, as very little of the drug reaches systemic circulation, resulting in fewer systemic adverse effects. So, for patients who experience adverse effects from budesonide that cannot be tolerated, cyclosinide may be an acceptable alternative. The steroids do come as combination products, with long-acting beta agonists as dual therapy with these two agents is extremely common in asthma patients. Inhaled corticosteroids have been shown to be more effective than montelukast and theophylline. The addition of montelukast or theophylline is as effective as doubling the dose of the steroid. However, adding a LABA to an ICS is the most effective and is more commonly done than adding oral leukotriene receptor antagonists or theophylline. Inhaled corticosteroids must be used routinely to be effective. As-needed administration does not provide benefit. Systemic adverse effects are less common with the inhaled route, but may be seen particularly in higher doses. Local adverse effects are more common, including oral pharyngeal candidiasis, a fungal infection of the throat, and dysphonia, which is a change in voice. Generally, women do not want a deep, manly voice. Next are the LABAs, or the long-acting beta-2 agonists, most commonly salmeterol or formoterol. Formoterol is quick onset, so it can be used as maintenance and for an acute asthma attack. LABAs generally provide bronchodilation for greater than 12 hours, whereas ultra-LABAs can provide bronchodilation for 24 hours. When LABAs are added to ICSs, they improve symptoms, lung function, and reduce risk of exacerbation. Montelukast is the preferred leukotriene receptor antagonist of choice. LTRAs are not an essential first-line agent, but are used as an adjunctive therapy in addition to primary therapies. Montelukast requires a prescription, and there are different doses in pediatric patients down to 2 years of age. Montelukast can improve FEV1 and PEF rate. It can decrease nocturnal awakenings, and it can decrease beta agonist usage and asthma symptoms. Montelukast has very minimal adverse effects. Montelukast can also be used for exercise-induced bronchospasm by taking 2 hours prior to activity. Not all patients respond to Montelukast, so if no benefit is seen, the medication should be discontinued. With such minimal side effects, it is relatively a harm-free option to try. Methylxanthines are older medications that are rapidly falling out of favor due to their significant toxicity profile. The toxicity profile and narrow therapeutic range is not the only concern when giving theophylline. There are also numerous drug interactions, including drugs that increase theophylline level, like macrolide antibiotics, allopurinol, propranolol, and ciprofloxacin. Drugs that can decrease theophylline levels include rifampin and several anti-epileptics, in addition to smoking and having a high-protein diet. Theophylline and aminophylline are the two methylxanthines commercially available and are very similarly structured to caffeine. The chemical structures of theophylline and caffeine are shown here. Theophylline is far more commonly used. It is generically available and comes in different formulations, most commonly a sustained-release tablet. Despite its dangerous toxicity profile and numerous drug interactions, theophylline is available without a prescription, whereas despite its incredible safety profile, Montelukast still requires a physician prescription. Plenty of side effects are seen at therapeutic doses as well. A supratherapeutic dose is not needed to experience frequent adverse effects. Long-acting anticholinergic tiotropium can be used in steps 4 and 5. However, this medication will be discussed more in depth in the COPD lecture. Anti-IgE antibodies can also be used in step 5 of asthma chronic management. Primarily, omalizumab is the most commonly seen anti-IgE antibody used. Due to its extraordinarily high cost of well over $10,000 per year, it is only cost-effective to use in a very few select patients, with many A&E visits and hospitalizations in a year. It is a subcutaneous injection given every 2 to 4 weeks that must be stored in the refrigerator. It takes a few months to start working. However, measurable response is seen in many patients. As with most antibody drugs, there are several side effects with the medication, including injection site reactions, anaphylactic reaction, gastrointestinal side effects, bleeding-related adverse effects, and so on. Lastly, I want to mention asthma in the special patient population of pregnancy, as it is the most common serious medical condition to complicate pregnancy. Asthma in pregnancy increases the risk of numerous health problems in the mother and baby. Most exacerbations occur during the second trimester, so monitoring may need to be more frequent during that time. Although the medications can increase the risk of problems for the baby, the increased risk from being hypoxic is far worse. Medications are the lesser of two evils, really. Also, heartburn can worsen asthma, so proper management of heartburn should be employed to reduce the risk of asthma exacerbation and the need for more asthma medications. Also, heartburn can worsen asthma, so proper management of heartburn should be employed to reduce the risk of asthma exacerbation and the need for more asthma medications. In summary, asthma is characterized by bronchospasm, excessive mucus production, and inflammation. The goal of asthma care is to normalize patients' lives and activities of daily living. Drug therapy is the mainstay of treatment, making it essential knowledge for a pharmacist. Drug usage should be minimized while maintaining control of the disease. Drug therapy is adjusted in a stepwise approach based on severity. These are the references. Thank you for your time and attention. This concludes the Introduction to Asthma Pharmacotherapy lecture.